this is something that allows us to work together on many occasions. My task is the one of updating you as to the clinical picture of this disease, while recalling that even if my time limit is only half an hour, I will try and take less than that. And let me just remind you of what are the specific characteristics of this disease, which is born, as you probably know, out of some patients' cases classified as Dravet syndrome. Then only afterwards we realized that when we conducted a genetic study, there was no mutation, the typical mutation of the Dravet syndrome, that is the SCN1A mutation. So we looked at this group of patients, most of them females, and we sort of defined more and more the entity, which was called PCDH19. And you will see that there is going to be a further new terminology, not only related epilepsy, PCDH19 related epilepsy. This is affecting mainly females, but it's not only confined to females. And the onset is between 3 and 36 months, the onset of seizures. And seemingly there is a normal psychomotor development before seizures, and after that we see the onset of different seizures, which are mostly cluster-like, both febrile and afebrile. And there is a tendency of the seizures to evolve towards the status epilepticus within a given age bracket. There is also a tendency to resist to the drug treatment, especially when puberty approaches, and this is when the resistance drops, and there is also an association with some behavioral and autistic-like or psychotic-like behaviors. There is a phenotype which is extremely and highly variable, which comes from a cognitive profile which may be almost normal and could go up as a very important delay. Here again we have seizures that are resistant to the drug, and we may evolve up to seizure-free situations. And you can see that on the right-hand side we have the first works which defined the first female group of patients that were standing out and were different from the typical Dravet patients and that did not bear the typical genetic mutation. So as to confirm this similarity, which could have been misleading at the beginning. And here you see this is a very famous diagram which has got to do with the Dravet syndrome evolution. There is a first febrile period, then there is an active worsening period, a stabilization period, and then there is another period which is characterized by febrile seizures. After that, we see the onset of other tonic focal absences, myoclonic jerks, and then we see the onset of neurological deficits, ataxia, walking syndromes, which are not typical of the proto-Catherine group or cluster. Then now here we have a group or a study carried by Chemanet, and here they were trying to see whether it is possible to detect the first phase going from 0 to 2 years, where there's onset of seizures, where there's a sensitivity to and an inclination to develop fever, which is quite evident. And there is another cluster-like seizure group, which is repeated with the appearance or the onset of a delay and behavioral problems. And then there is a stabilization phase, which is coming after the age of 10 years, where the seizures tend to decline, and sometimes they even disappear, but there is a more predominant psychiatric picture. Now here, this is marked as one of the fundamental hallmarks of the proto-Catherine associated epilepsy, which comes in clusters. And For some 2 years, we tend to use the PCDH19 girls clustering epilepsy, which is GCE. And this is a way to define the syndrome because we tend to stress the tendency of having a cluster-like onset. But while analyzing in depth the onset of the different syndromes, the two different syndromes, you can see that there is this work conducted by our group, which has got to do with the sensitivity to febrile crisis, and there is a fever sensitivity, and you can see that the onset age, I wonder if we have a pointer, says the speaker, because he cannot point at the relevant aspects in his own slide. Do you have a pointer, maybe? Or anyone has one? And by analyzing the febrile seizures of the two entities or the two groups, you can see that the onset age is different because the onset age in the Dravet syndrome is always taking place before the 12th month of age. And in protocadherin, that is running from the 6th month up to the 2nd year of life. And the typical characteristic Dravet syndrome, we tend to have prolonged status epilepticus periods, clonic and myoclonic and tonic seizures. With protocadherin, we tend to have a repetition of short seizure clusters. And recently, there was a work published by a French group which was analyzing the characteristic of 13 cases of protocadherin, and they tried to look at the characteristics of the epilepsy. Now, I'm not touching upon the genetic aspects, but we would like to say that there are de novo cases, 12 de novo cases. The onset age is probably higher as compared to the Dravet syndrome, because in the Dravet syndrome is of 10 months, with a range going from 4 to 10 months. And there is a tendency to have a cluster-like onset already in 12 cases out of 13. So this seems to be a true marker of this disease. And the fact that there is a presence of fever is not as to be given for granted, because we can see that there are only 4 cases having an onset which was provoked by fever. And in the other cases, we had a cluster which appeared without any triggering factor, so there was no pediatric condition which was connected. The seizures may be focal, generalized, and the focal crises or seizures are very often having a tonic component with a head deviation, which is tilted on one side. And we see that here there is already one aspect shown, that is when there are focal crises, there is often another component which is related to fear, to a real dread, which appears on the face of the child who is outcrying, who is screaming whenever he has a seizure. And in a good percentage of focal seizures, there were manifestations of dread and fear. And the cluster characterizing that trend, epileptic trend, may last hours, a few hours, sometimes can be as long as a week. And apart from focal seizures, there may be generalized seizures, tonic-clonic in patients who tend to be subject to generalized seizures. And we see that there have also been some descriptions of absences. And a few EEG patterns were describing it well. Then in the case of evolution, the clusters tend to thin down and disappear, and after the age of 12 years, the cluster tends to almost disappear, and it goes back to normal. Here we have a work which was conducted by Marina. This is a multi-center study. They analyzed the types of different seizures. Here we see the focal seizures with the motor component, where the onset seems to be time-related. And here we have another type of seizure without a motor component. And usually these seizures tend to last 1 minute, maybe sometimes 70, 80 seconds. They are short. Then there are other more prolonged seizures, such as this one, which is lasting almost 3 minutes, where there is a poor motor component, but there is a strong behavioral disorder and component. And the Here we see the recording of true absences. And this is our group where we have a burst, which is showing a generalized pattern. And with these patients, there are some intercritical basic moments that have been recorded. Many recordings were conducted during the typical seizure cluster. We see that there are some abnormalities at temporal frontal level. There are some very rapid rhythms, as you can see, that are more temporal and occipital in some cases. Then there are other cases with generalized seizures where we can record an intercritical EEG with a typical peak and wave kind of generalized trend. And very recently, Marina Trevisano and Nicola were conducting a bibliographic survey, analyzing all of the cases described and coming with a status epilepticus. And it's hard to define the difference between cluster and status epilepticus, but in the greatest number of cases, the patients were presenting with the prolonged and repeated seizures. And here you can see the case numbers that were put together. And this was allowing us to review a number of works. They themselves were reviewing some 60 works. This is a publication that was very recently appearing, and I would like to summarize a few data. There seems to be no gender-related difference, especially as far as the onset of the status epilepticus, and the general age was of 12 months in terms of onset. Then there was a precise definition of semiology, which was reported only in 17 cases. And in 15 cases, there was a motor seizure component. Only in 2 cases there were no seizures. And you can see that there was a great difficulty as far as the control of the status epilepticus. And in the end, there was only an intravenous administration of benzodiazepine, but in most cases we could keep the status epilepticus under control. I know that today during the roundtable we will get back to this topic and we will be discussing it once again. And here now I would like to show you a few more things. And one thing which is noted by almost all of the authors is how during focal seizures there is this strong incidence of affective component seizures with a strong fear and typical dread, which is almost a marker of the cluster seizures pattern displayed by these patients. Now, take a look at this child. This is a little boy, and this is showing how this seizure with accompanied by fear Now, you can see at that face expression, which was very visible, it is a typical marker of this condition. So much so that we found it even in another male patient. That was the first case of mosaicism. And the situation and the pattern was so similar of the female cases with protocaterin, so much so that we looked at the PCDH19, and that patient was a mosaic patient. There are other cases described in literature which are very similar to this one. But once again, unfortunately, I believe that you cannot read it, but this is a further confirmation of the study that was conducted by Marina. And here again, they are noting that more than 80% of the patients having focal seizures have seizures with a typical component of fear shown by the face expression. Now, this was a study conducted by Marina. She put together many case numbers. This is a multi-center study where protocaterin patients were studied. I know that you cannot read, but anyway, the conclusions are that the more early the onset of the disease and the easier and the higher the incidence of behavioral disorders, of ID, and of autism. Now here you can see the concept showing that the seizures in the course of time tend to disappear and to become more sparse. Now this is the typical trend of epilepsy, with an onset taking place in the first 2 years of life. Then there is a stage where seizures appear with a typical cluster pattern, and then at around the age of 9-10 years, when puberty is approaching, there is a reduction of the frequency of the seizures and of the number of clusters. Then at the end of the follow-up, now I know that here we have some 60 patients, but you can see that some 13 patients, almost 20% of them, went on having frequent seizures, and almost 70% of them were having sporadic seizures, and only 15% of them were completely seizure-free. That is to say, no seizures at all. Then, during puberty, we observe an evidence of behavioral problems, so much so that in recent periods, in recent times, some cases were described, patients with clustering epilepsy and protocadurin, and there is a trend towards a reduction of the severity, but almost 1 case out of 5 presents with a typical psychotic manifestation, which is compatible with schizophrenia diagnosis. Now, going back to Marina's work, and this is a multi-center work, I'd like to say that one of the fundamental aspects and points is that it seems that there is an incidence between ID and autistic behaviors and the onset, the age of onset. So the earlier the age of onset, and the higher is the possibility of having some intellectual deficits, together with other symptoms that fall within the picture of the autism spectrum disorder. And this is something which is well known. Even in the case of the Dravet syndrome, we know that, as a matter of fact, what determines the severity of the phenotype, the intellectual phenotype, and of the behavioral problems does not seem to be connected directly to genetic mutation types, but rather to the onset, to the age of onset. And this is one thing which is worthwhile looking at. Also, the fact of having an earlier age of onset may define the trend of the phenotype, the evolution of the phenotype, or maybe, to the contrary of this, there may be already a genetic mutation which leads towards a genetic mutation, because the case is a severe case, more severe than any other cases. I could also go on by saying that there are other cases, such as the ones of focal epilepsy, which are highly stereotyped. And we've seen, as a matter of fact, that in these cases there are other abnormalities, such as focal abnormalities, and they were all cases of protocadurin patients treated surgically for epilepsy without having any success at the end of the surgery, because there was this genetic mutation which was a predisposing factor, whatever the lesion was. And we know that there also was another incidence shown by X-rays. Now, here we have another aspect which is highly criticized, that is to say, whether the PCDH19 gene may be accountable for some situations that are of a pure psychiatric nature in the absence of seizures, because there have been some cases studied with the presence of schizophrenia with early childhood onset. Most of them were males, and they started looking for the genes, and the genes were found, and they were associated to other conditions. And at least in one case, there was a PCDH19. It was not a typical mosaic case. So as a matter of fact, we will probably have to discuss about this condition which was described as a purely pathogenetic, random kind of situation. Nonetheless, we cannot exclude that psychiatry situations are connected to the PCDH19 without having had any further expression of this disease status or of epilepsy. One last comment before coming to the end, and this has got to do with the treatment. And I would like to point out this aspect because this leads us back to the Dravet syndrome and the mention made of stilipentol in girls treated and with protocadherin that had to do with the fact that when stilipentol was described and its efficacy was described, as a matter of fact, we didn't have any knowledge of the gene. And in that very original case number, we also had some PCDH19 cases included. So I would like to say that there have been some good results. I wonder how much this was then further digged into on a number of different cases with a specific attention paid to the effect of stilipentol. Now, I would like to conclude with a few more points. And here I go back to the key points of Marina, the ones she highlighted at the end of her work, where she was highlighting and stressing the point that how the early age of onset is affecting from the intellectual disability and psychiatric disorder point of view, is influencing the situation, because epilepsy after a very hard onset, which is characterized by clusters, and we have to include this term in the definition of this disease, because this is something that tends in the course of time to decrease, so much so that after the age of 10, 12 years of age, the number of seizures and the clusters may decrease markedly. There are some expressions of fear and of terror, which are a true marker, especially in most focal seizures. And then we see how very difficult it is to make this correlation to the phenotype, especially whenever we consider all of the other aspects having to do with this condition. Many thanks for your attention.